This lecture is going to be on Chapter 18, Fibrinogen, Thrombin, and the Fibrinolytic system. At the end of this lecture, the student will be able to recall the role of fibrinogen in the coagulation and fibrinolytic systems, describe plasmin in terms of activation and inhibition, differentiate the role of thrombin in the coagulation and fibrinolytic systems, outline the inherited disorders of fibrinogen, define conditions that may precipitate disseminated intravascular coagulation or DIC states, describe laboratory testing and management of patients with DIC, and lastly, describe laboratory testing for thromboembolic disorders. Fibrinogen is the principal substrate of the coagulation system. It has the highest molecular weight of all of the clotting factors. It's heat labile, meaning it is unstable when it is heated, but it is stable once it's in storage. The reference range for fibrinogen is 200 to 400 milligrams per deciliter. Its activated clotting factors accelerate the activity of other factors. There's a negative feedback mechanism that happens by the naturally occurring inhibitors that help keep the hemostasis system in check. Cross-linked fibrin is stabilized with the assistance of factor 13 and thrombin. Fibrinogen consists of three pairs of polypeptide chains. We have the alpha chain, beta chain, and gamma chain. And what happens is the thrombin cleaves small portions of the alpha and beta chains, and this helps to create fibrinopeptides A and B. Once these fibrinopeptides have been cleaved, the fibrin monomer is actually created. So then thrombin activates calcium and factor 13, which creates factor 13A, forming a peptide bond between the fibrin monomers, which produces a stable clot. Patients may have disorders of fibrinogen. When a patient has a decreased fibrinogen, the result can come from an acquired disorder such as acute liver disease, acute renal disease, or disseminated intravascular coagulation, also known as DIC. An acquired increase in fibrinogen may be demonstrated in patients who have hepatitis, may be seen in pregnant women, and also patients with atherosclerosis. There are three inherited fibrinogen disorders. They're a little bit of tongue twisters. So first you have afibrinogenemia, hypofibrinogenemia, and lastly dysfibrinogenemia. These are inherited conditions that are rare and, depending on the severity, are marked by hematomas, which is bleeding under the skin where there's actually swelling of the clotted blood that's pooled below the skin, hemorrhage, which is bleeding out, and ecchymosis, which is also a bleeding under the skin, but it's more of a discoloration, otherwise known as a bruise. Afibrinogemia is homozygous autosomal recessive. It shows less than 10 milligrams per deciliter fibrinogen in the plasma, with the normal range again being 200 to 400 milligrams per deciliter. You may have bleeding from the umbilical cord, poor wound healing, or even spontaneous abortion, which is also known as a miscarriage. When it comes to the laboratory results for afibrinogemia, you're going to have an increased PT and PT time, an increased thrombin time, and an increased reptilase time. And we'll get to the TT and reptilase time in just a minute because we haven't discussed those previous to this lecture. Results may also show abnormal platelet aggregation with most aggregating agents, meaning there will be elongated bleeding times. So backing up to thrombin time in the book, This is in the book, which you can read about. The thrombin is an assay that uses thrombin as a substrate to measure the time it takes for fibrinogen to be converted into fibrin. Reptilase, and it kind of sounds strange, is a coagulation procedure similar to the thrombin, except that the clotting is initiated by reptilase, which is a snake venom. And using the reptilase, heparin would not affect the assay. Heparin is an anticoagulant. So that's just a brief overview of those particular tests. And again, those would be increased with afibrinogemia. Treatment for afibrinogemia would be cryoprecipitate, which contains fibrinogen, specific clotting factors such as von Willebrand's factor, factor 8, factor 13, and fibronectin. Also, treatment could be just fresh frozen plasma, and fresh frozen plasma would have all the clotting factors. Hypofibrinogemia is a heterozygous form of afibrinogemia. It's autosomal recessive. Patients will have 20 to 100 milligrams per deciliter of fibrinogen in their plasma. Again, the normal range is 200 to 400 milligrams per deciliter. Symptoms for hypofibrinogemia would be mild spontaneous bleeding or severe post-operative bleeding, meaning a post an operation where someone has been intentionally cut into or worked on. Results of laboratory testing is going to depend on the fibrinogen that is present, so it may be prolonged or it may be normal. Dysfibrinogenemia is autosomal dominant. It's inherited homozygously and heterozygously. It's a qualitative disorder of the fibrinogen where an amino acid substitution produces a functional abnormal fibrinogen molecule, and then it affects the fibrin formation. This condition is not, it's infrequently or not associated with a bleeding tendency. Laboratory results or laboratory findings for dysfibrinogenemia would be normal immunologic assay of fibrinogen, an increased PT, PTT, TT, again that's thrombin time, because we have not discussed that previously, and RT, which is reptilase time. The assay for the quantitative fibrinogen is going to be abnormal, and this is because it depends on not just the proper amount of the fibrinogen, it also has to do with the functionality or the properly functioning fibrinogen that's present. Thrombin is generated in small concentrations through the injury to the endothelial cells. Thrombin plays multiple roles in hemostasis. It participates in the platelet release action and the platelet aggregation. Secondarily, it stimulates platelets to produce prostacyclin or PGI2, which is a platelet inhibitor. Prostacyclin, yeah, I said that one right. It activates factors 5 and factors 8 as well. Thrombin also activates protein C. Protein C, along with protein S, combines with thrombomodulin to inhibit factors 5 and factors 8 to diminish the clot-forming activity. So thrombin is actually a procoagulant and a key player in the role of the process of fibrinolysis. Here you have a visual of thrombin's role in fibrinolysis, where it stimulates platelets into platelet aggregation. It converts fibrinogen to fibrin, plasminogen to plasmin, protein C into activated protein C. It promotes, by doing all these things, it also helps promote wound healing and tissue repair. Fibrinolysis is clot dissolution or the breakdown of a clot, and this usually occurs several hours after a stable clot has been formed. A key component in this process is plasminogen, which is a plasma enzyme that is synthesized in the liver. Plasminogen is converted to plasmin by TPA. TPA is tissue plasminogen activator. The TPA is a substance that is actually released as a byproduct from endothelial cell damage and the production of the thrombin. Plasmin digests both fibrin and fibrinogen. TPA can be synthesized by recombinant technology and used as a fibrinolytic therapy for patients who are having stroke episodes. So it's actually used as a pharmaceutical product and considered a clot-busting drug. Other plasminogen activators are factor XIIa, kallikrein, high molecular weight kininogen, or HMWK, urokinase, which is a protease that's present in our urine. It can be used as a commercial product in thrombolytic therapy for patients with heart attacks, strokes, and other thrombotic episodes. Streptokinase may be used, which is an exogenous fibrinolytic agent that's produced when bacterial cell products combine with plasminogen. There are naturally occurring inhibitors of fibrinolysis. These are products that restrain fibrinolytic activity to aid the balance of hemostasis. So plasminogen activator inhibitor 1, or PAI1, is one of those inhibitors. It's secreted by our endothelial cells during injury. It suppresses the function of the TPA that we just talked about, the tissue plasminogen activator. Other naturally occurring inhibitors of fibrinolysis are alpha-2 antiplasmin. This prevents plasmin binding to the fibrin, so it stops the lysing. It's the most important inhibitor of the fibrinolytic system. Secondary agents that can inhibit fibrinolysis are alpha-2 macroglobulin, C1 inactivator, and alpha-1 antitrypsin. These substances act upon the thrombin formation themselves. There are measurable products of the fibrinolytic system. Fibrin split products or fibrin degradation products, FSP or FDP. These are composed of early and late fibrin fragments. They can be D fragments or E fragments. They can be known as D dimers, which is a type of the FDP or fibrin fragment. Their presence indicates that fibrin was formed and subsequently broken down by the fibrinolytic system. It's released when the clot is dissolved by plasmin. We have a D-dimer assay testing now that's used to assess whether or not a patient has a DVT or deep vein thrombosis or PE, pulmonary embolism, which we've spoke about on previous lectures. It's useful in monitoring thrombolytic therapy, which are patients that are receiving IV meds to stop any type of clotting issues they may be having. Here's a chart that shows you some conditions that may elevate the D-dimers. Therefore, when you run the D-dimer assays, they would be elevated. So we have disseminated intravascular coagulation, pulmonary embolism, deep vein thrombosis, venous thromboembolism, coronary artery disease, infection, pregnancy, renal disease, malignancies, and trauma. DIC, or disseminated intravascular coagulation, is usually triggered by an underlying pathological event, and it's usually a severe event that cannot be predicted, and it can be potentially fatal. The hemostatic system becomes unbalanced. Our hemostatic system is a process of the different processes of vasoconstriction, the platelet plug formation, and the blood clotting processes. The coagulation system, fibrinolytic system, or both can be hyperactivated. The condition is systemic and leads to excessive disposition of thrombi or clots and excessive hemorrhage or bleeding out. The process that occurs with DIC is consumptive, meaning it's destroying clotting factors and platelets as soon as they are activated for coagulation. DIC is associated with obstetrical complications, meaning the process of having a child, childbirth, malignancy, massive trauma, bacterial sepsis, which means a patient has acquired some sort of infection that has been underlying, has not been treated, and it will eventually reach a heightened state where it crosses over into the patient's blood, which is highly dangerous and needs to be addressed immediately. Asplenia, which means the spleen is still there, but there's some sort of absence of normal spleen function. Also, if there is any type of necrotic tissue, which means the tissue doesn't have the correct blood flow, is considered non-viable. The mechanism of acute DIC is when the negative feedback system is impaired or missing. The DIC cycle is when excess thromboplastin triggers excess thrombin, which triggers coagulation and therefore fibrinolysis. Spontaneous enzymatic conversion of the fibrinogen to fibrin. The plasmin generation degrades fibrinogen or the fibrin into FDPs. Again, that is fibrin degradation products. And then the excess of FDPs are formed. The excess FDPs degrade soluble fibrin monomers, and the plasmin causes inactivations of factors 5, factors 8, factors 11, and factors 12. Within the DIC cycle, in excess FDPs, monomers are degraded, clotting factors are inactivated, which is going to lead to hemorrhage. Clots that are formed are not stable, contributing further to the bleeding. In DIC, bleeding is the major result secondary to platelet and clotting factor inhibition, overactive factor inhibitors, and faulty fibrinolysis. The condition related to DIC is the primary fibrinolysis, activation of plasmin within the circulation by sources other than the thrombin. The plasmin acts on fibrinogen and fibrin, making the hemorrhage inevitable. The platelet count is normal when it comes to primary fibrinolysis, unlike the platelet count in DIC, which is abnormal. Clinical symptoms and laboratory results in acute DIC. We have hemorrhagic episodes where you're going to have bruising or ecchymosis, epistasis, which is nosebleeds, petechia, which are pinpoint dots of blood under the skin. In thrombotic episodes, you can see acrocyanosis, where blue or purple mottled discoloration occurs on the extremities, especially in the fingers, toes, or even the nose. Hypotension may occur, which is when the patient's blood pressure is low. The patient may be in shock. Microthrombi will occur, which are microclots, teeny tiny clots in the smaller vessels. Those microthrombi places that the microthrombi may be found are in the nose, genitalia, in your digits, meaning your fingers and toes. Major organs as well, such as the kidney, the liver, and the brain. Clinical symptoms and laboratory results in acute DIC. So laboratory results, the PT is going to be prolonged. The PTT will be prolonged, a decrease in fibrinogen, a decrease in the platelets. Your FDPs are increased, and schistocytes may be seen in the smear and the CBC smear, which are teeny tiny little misshapen parts of red blood cells. D-dimers will be increased. The D-dimer results are an essential piece of data in emerging DIC patients. Other pathologies where D-dimers may be increased, such as inflammation, renal disease, a local clot, may also elevate these results. Treatment for acute DIC is identifying the precipitating event that led to the DIC. Usually points more towards a successful treatment. So there's a widespread use of antibiotics in the case of septicemia. So if the patient is septic and therefore that's what's causing the DIC, you want to get to the root cause and treat that with antibiotics. If the precipitating event were surgery with OB complications, you'd want to treat that as needed. Treatment in acute DIC can be FFP or fresh frozen plasma, packed red blood cells, platelet concentrates, and the use of heparin combined with antithrombin may also be a good treatment as well.